Welcome back, everyone. We'll now start the second panel, preparing for future pandemics and contagious outbreaks, surveillance and evidence-informed responses. I will be introducing these speakers who will be presenting their work, and we'll have approximately 30 minutes at the end for questions. So if you have any questions at any point in the presentations, be sure to enter them in the Q&A, and we'll do our best to answer as many as we can. First up, we have Dr. Gabriel Fabro. Dr. Fabro is Assistant Professor in the Departments of Medicine and Community Health Sciences and co-leads the Refugee Health YYC Research, Innovation and Education Platform at the Cummings School of Medicine. His research interests include health services, clinical and public health research with a focus on the health of recently arrived refugees, socially vulnerable populations, and complex chronic disease. Dr. Fabro will speak to us today about evidence-informed pandemic response for new Canadians. Welcome.
Perfect. Thanks very much. I'm on service in hospital at the Lougheed, so if this pager goes off, my apologies if I just bolt out in the middle, but I hope I can make 7 minutes. Next slide, please. I don't control the slides, right? Okay. So one of the things we've learned in the pandemic, unfortunately, was abundantly clear in North America is that it disproportionately affects some populations, communities, and neighborhoods more than others. And in Canada, and the same as any high income country, this is our low income populations, racialized populations, frontline essential workers, and First Nations peoples in Canada. And this has been abundantly clear through 5, now 6 waves of COVID. Next slide, please. I could summarize 2 years of data, but I think this slide from the Ontario Science Table 2 months ago really does a great job. Across 5 waves of COVID, you can see that according to the income quintile, the neighborhood you live in really determines your risk of dying. So the dark bars on the left are your lowest income neighborhoods, and the lighter bars on your right are your higher income neighborhoods. This is all Ontario data. Alberta hasn't published this, but Calgary is one of the most income unequal cities in the country. And so there's no reason to believe it wouldn't be the same or worse. Next slide. So in our hands, as Danielle mentioned, I do a lot of work in refugee health, and as a result, work pretty closely with a lot of immigrant serving community agencies. And in Alberta, we had the dubious distinction of having the largest outbreaks in North America early in the pandemic in our meat plants. And the meat plants are important for the food supply. So the 3 large meat plants in Alberta for beef provide about 80% of the beef supply for the entire country. And they're largely, the workforces are very big, and they're largely comprised of newcomers, racialized newcomers, temporary foreign workers, facing a lot of the barriers previously mentioned. Next slide. So we were called in early in the pandemic, Dr. Coakley and I, to help assist, call in the social agencies and help with the outbreak management. And then it led to research into the meat plants and risks. And early in COVID, when we knew very little, it became blatantly clear that they're very high risk environments. And over time, built a lot of relationships with the communities. And then later on, we're invited, each time there was an outbreak, invited back to help guide some of the scientific policy, which led to a big round table in about February 2021 with industry, government, and unions and everyone. There we presented some scientific evidence around why it'd be important to prioritize the meat plant workers in high occupational risk settings for vaccination. We had to advocate quite a bit, and then fortunately our policy proposal was approved for the province. We then moved to vaccinate the 4 meat plants, organized vaccination and evaluation of the 4 meat plants around Calgary, and achieved an 85% uptake across both doses. And this is at a time where it was, at the time, the largest and first on-site large-scale occupational vaccination clinic in the country. And we used a lot of the community engaged approaches that are proposed and evidence-based by the WHO. And the rest of the province, to show you the difference in approach, the rest of the province had a median, including the oil fields, of about 41%. And so we did an evaluation around that. Next slide. We then took that information and turned our attention to the northeast of Calgary, where I am now, And in Alberta at the time, and still today, it was upper Northeast Calgary had the highest incidence and prevalence of COVID over the entire pandemic. Lots of, again, racialized workers, frontline workers who can't stay home. It also had the lowest uptake of vaccination despite having vaccines widely available for months at the time. And so, next slide, we went to the communities and worked with the partners and leaders, and the community had concerns. They told us there's a lot of shift workers that aren't able to access the normal 9 to 5 appointments through the health system or pharmacies, a lot of health literacy, language, transportation barriers, navigating phone and computer systems, very difficult. The communities also mentioned they felt really blamed and disempowered because of the high burden of illness there. And they wanted all families to have appointments together instead of single. From the health system side, there were concerns around lack of appointments, and what we'd proposed was a low barrier, just walk up model, as had been done in Toronto and some other jurisdictions. But there was concerns that the targeted communities wouldn't come, that there would be crowds and so on. And the health system really is not used to working with community agencies in partnership. And so again, after a lot of work and advocacy and discussions, next slide, we were able to host Alberta's first low barrier community engaged walk-up vaccination clinic in Northeast Calgary. And being Canada, we appropriately hosted it in an empty hockey arena. Next slide. And so I led the evaluation as part of, and co-led the design, and we delivered about 2,300 vaccines over the weekend, 70% around. So we geocoded postal codes at the door, and found that about 70% were from the target areas. 75% frontline workers, highly racialized. Most didn't speak English at home. There's a 2-minute wait time at the door, 40-minute in and out, and almost universal satisfaction. Some of the research that we did, importantly, highlighted that over a third of the patients that came had actually tried to access the regular health system vaccine, but couldn't navigate. Next slide. And so again, as per the evidence, we built a big coalition across healthcare, academia, government, the city of Calgary, community partners, and then lots of community volunteers. And this is part of that evaluation that showed there was about almost universal acceptance with the model. Next slide. And it was really fun, working in hospital. We've seen a lot of terrible things, and so having a lot of specialists and physicians and volunteers come and be able to protect the communities that we serve in hospital was really empowering. Next slide. We call those the album covers. And then amazingly, the community outreach program ended, but by November, that was June, and then by November, upper Northeast Calgary achieved universal vaccination, 99.6% vaccination rates, and everyone above age of 12 on their own. There was a couple of more outreach clinics shortly after Village Square, but then the communities did it on their own. And so this really is an anomaly across metropolitan centers in North America, where your highly racialized, highly marginalized community has universal first dose coverage, and it really should be celebrated. Next slide. But unfortunately, we stopped. And so this is a slide on the left. We have the lowest vaccination rates in the country for third dose, and we have the lowest rates for child vaccination rate. And these are data that I pulled from a week ago. Not only did we give up the community outreach and community engage methods that have been proven to work, we regressed. And so for children, there was a single site vaccination for the longest time for the entire northeast quadrant of the city and East Calgary. And you can see from the west of Calgary, where among the highest income neighborhoods to the lowest income neighborhoods, there's a twofold disparity in vaccination rates for children. So last slide. What is our role in public health? Well, disparities exist. Ed Yong said last week in a piece that medicine moves upward and pandemics move downward through the cracks of society. All of this has been gendered and marginalized and based on income. How do we advocate against misinformation? And what do we do about these inequities that have been exposed and worsened through COVID-19, especially given that the pandemic's not over? And I'll leave you with a quote from a professor of mine, shoot, I'm a minute over. Paul Farmer is a hero in global health, and I had the privilege of studying under him for some short time. He said that with rare exception, all of our most important achievements will come from working with others. Thanks very much.
Thank you. Next, we have Dr. Michael Perkins. Dr. Perkins is an associate professor in the departments of medicine, microbiology, and infectious disease in the Cummings School of Medicine. He is one of the province's COVID-19 wastewater co-leads and is working to advance this technology and other analytes, including antibiotic resistant organisms. Today, Dr. Parkins will present about the Alberta's wastewater surveillance work. Welcome.
Thanks, Danielle. Next slide, please. So wastewater-based epidemiology is an emerging field of science, one that is quite analogous to performing phlebotomy to understand the health of a host. We take sewage samples and wastewater samples from different scales of the sewer network to understand with increasing granularity the health of the population that is drained by that particular sewer network. If you can advance this slide. What's important about this technology is it's comprehensive. It captures everybody in a sewer shed network. It's inclusive and excludes no one, and it is objective and unbiased, which is very different than many of the other means of tracking pandemics, including clinical testing. Next slide, please. The process by which we analyze samples is quite complex, and I won't go into details, but sample collection requires us to collect samples from sewer sheds, whether it's a wastewater treatment plant or individual buildings. We capture 24-hour samples to recognize the diurnal toileting pattern of human populations. The samples then need to be cleaned and concentrated. We are looking for the proverbial needle in the haystack here. The average Albertan uses 450 liters of water per day, and we need to concentrate a wastewater sample from millions of liters down into a tiny fraction that we assess for molecular signals. Those signals we look for are the same that are looked for in the clinical laboratory for SARS-CoV-2, as well as internal controls and external controls that we spike. And then we do reporting and actions based on those data. Advanced slide, please. Our current Wbe program covers Alberta, the city of Calgary, and a range of targets within the city of Calgary, from the wastewater treatment plants to what we consider high-risk individual facilities and communities, be it hospitals, schools, a university campus, jails, shelters, First Nations communities, although I'll focus my talk on just a couple of areas. Next slide, please. As part of our early work, we wanted to understand the degree of granularity with which WBE could provide impactful information to a community. And we set about on a program over 6 months where we collected wastewater samples twice weekly at a range of scales. From each of the wastewater treatment plants, from which we were able to create a single aggregate citywide metric, as well as through eventually up to 8 individual communities through the city of Calgary, where these neighborhoods had 12 to 28,000 individuals residing in them. And then we compared our wastewater signal with the residents of clinically diagnosed cases reported to public health, limited to the 3-digit postal code. And what we could find is that there were strong correlations between clinical cases and the wastewater signal at all ranges of scales. But the further we zoomed out, the more precise the signal was. This is perhaps a bit of an artifact based on the fact that we were limited to 3-digit postal codes, which aren't terribly precise themselves, but also reflects the fact that as individuals, we don't live exclusively in our home neighborhood. We move in and around the city, and in so doing, people will use the restroom facilities wherever they may be. Next slide, please. We've looked at high-risk facilities, and the area where we've had the most impact and the greatest learnings has been hospitals. Right now, we're monitoring all hospitals in Calgary. We originally went to hospitals as a positive control at a time of low COVID-19 endemicity in the community back at the trough of wave 1. And we weren't surprised to find that as cases increased in hospital, the proportion of wastewater samples that were positive for SARS-CoV-2 increased. But by and large, values were very, very low and sometimes even absent with a number of people recovering from COVID-19. But we continue to observe very large spikes that happened in the wastewater. And when we analyzed this, these were attributable to hospital-acquired infections and specifically unit-specific outbreaks. And for the first time, this recognized that the wastewater signal that we detect of SARS-CoV-2 in our sewer shed is that of acutely occurring cases as compared to those that are resolving, and that this is probably in the first day or two of symptoms. Next slide, please. Currently, our Pan-Alberta wastewater monitoring program is co-led by teams from Calgary and Edmonton. In Calgary, Casey Hubert and Kevin Frankowski and myself, and in Edmonton, Lily Pang, Benita Lee, and Steve Rudy. We worked with a huge range of professionals to enable monitoring of about 40 cities, towns, and First Nation communities. And this represents more than 80% of Albertans. And almost every community we approached to participate did get involved. And of course, we look at high-risk facilities as well, but we don't share those data with the public in real time. Next slide, please. The data that we generate is important for decision makers, but it's also important for the public. And because of this, very early in the pandemic, we partnered with Danielle, Alex, and Tyler from the Center of Health Informatics to build a data sharing platform that everybody can use. Danielle, I'm not sure if you can actually click on the picture itself, but it'll take us directly to the website. And it can show how the COVID tracker can be used in real time. That might not be possible here, but people can easily go to the website themselves and look. Within the website, you can actively click on individual communities throughout the province of Alberta and look at the trend of SARS-CoV-2 values over time. We report the different regions of the nucleocapsid gene that we're monitoring, and you can adjust the parameters to better understand things. And the idea is that people can use this resource to help to modify their own risk behaviors going forward. Next slide, please. And it's not just SARS-CoV-2 total virus that we can look at in wastewater. We can look for specific variants within wastewater. And there's a number of strategies that can be adopted. Some groups are using shotgun metagenomics, where we concentrate and sequence absolutely every RNA fragment in wastewater. That's terribly expensive and takes quite some time to do. So we've developed a process by which we either create or adapt model systems to differentially amplify variants based on allelic mutations in different regions of the SARS-CoV-2 genome. And we've been able to watch how different variants displace each other. Next slide, please. So this is a slide from around Christmas time during the 5th COVID-19 wave, as we watched Delta be supplanted by Omicron. And what we saw over a matter of days through each of the communities that we were monitoring across Alberta was a rapid displacement occurring. Now, what was interesting is that this displacement was strongly correlated with the community's location from an international airport, either in Calgary, Edmonton, or Fort McMurray, with the exception of Banff, which is the very first red line that you'll see on the top graph, which spiked very rapidly. And of course, almost certainly reflects the international visitors that Banff sees, as well as the high proportion of congregate living that exists for seasonal workers in Banff. Next slide, please. Now, what's important about WBE is that while COVID-19 has demonstrated the true capacity of this, that this is merely a platform technology, and it can be adapted to many, many, many different targets to truly understand the health of the population that is being captured by a sewer shed. Next slide, please. So a team of us here in Calgary have onboarded SARS-CoV-2 mimics, so viruses that cause respiratory syndromes that could overlap with COVID-19, because again, it's not so important to know merely what is not causing disease, but what else exists in the community at any given point in time. And we've developed and onboarded assays for influenza A and B, influenza A, of course, having a very great pandemic potential, and respiratory syncytial virus. And I'll just walk you through one example, which is our influenza A platform, if you wouldn't mind. Next slide. And here we've developed assays by which to look at specific genomic targets on influenza A and have measured these in our wastewater. In what you see here is North Alberta on the first slide. If you move to the next slide, West Alberta, and finally the last slide, South Alberta. And what you can see is that we've had big peaks generally between weeks 16 and 20 of 2022, and that this strongly correlates with the clinical disease that we've seen. What's important is this was actually an influenza season, whereas last year we had so few influenza cases, we probably wouldn't have been able to pick them up even in our wastewater at that time. But we have demonstrated this technology has capacity going forward. Next slide, please. We can look at antibiotic resistance, and we have programs looking at measuring antibiotic resistance at the range of hospitals, long-term care facilities, to measure dynamic changes to look for how organisms enter and affect the ecology of individual areas. And we have programs looking at antibiotic resistance across the sewer shed of large and small communities to, again, understand factors that drive those agents that do pose such great health risks in the future. Next slide, please. And finally, not every epidemic relates to infectious pathogens. And of course, we have an epidemic of drug-related overdose. And the technology that we have in our Aqua Lab here at the University of Calgary, Advancing Canadian Water Assets, has been adapted to look for and measure substances of misuse in wastewater, such that we can actually get great insight on this next and very important epidemic. Last slide, please. So what we've demonstrated is that WBE can be developed. Calgary wasn't a program that had WBE before the pandemic, and we very quickly scaled up and developed a program through transdisciplinary collaboration. We've determined that we can attract SARS-CoV-2 at a range of scales through a sewer shed, and that the signal we identify correlates strongest with acutely occurring cases, those that are transmissible. So it tells us where the active hotspots are. And it has the capacity to revolutionize public health, stewardship, and infection control. But of course is not amenable to every pathogen. It's dependent on pathogens that are shed in feces or urine, and that's not all of them. And of course, host factors will impact our ability to identify things. We've examined SARS-CoV-2 at a range of scales and spent a lot of time and effort in certain areas where we've then gone on to understand, well, hey, people don't use the toilets here. We're not going to find any signal here. Next slide, please. Our team is massive and very talented, and it wasn't without tremendous effort from faculties of science, engineering, and medicine that this work wouldn't have happened. That's all for my formal presentation. Thank you.
Great, thank you. Next, we have Dr. Stephen Friedman. Dr. Friedman is Professor of Pediatrics and Emergency Medicine at the University of Calgary. He has published over 200 peer-reviewed manuscripts and has received funding from CIHR, Alberta Innovates, the Canadian Immunity Task Force, Health Canada, and the Public Health Agency of Canada to study COVID-19 in children. His research focuses on applying clinical research to improve outcomes in children seeking emergency department care. Welcome, Dr. Friedman.
So the research that I'm going to describe really focuses on the work done by two different networks that I'm heavily involved in. On the left here is a map showing the Pediatric Emergency Research Canada sites. There are 15 sites located across the country from coast to coast, and we've been conducting collaborative research now for over 25 years. And we are part of what is also called PERN, or Pediatric Emergency Research Networks, which is a collaboration of 8 pediatric emergency research networks located across the globe, from Canada to the US to Central South America and as far away as Australia and New Zealand. And so by working together, actually, we initially realized that this was going to be a global pandemic, and we were able to build on an existing infrastructure that existed within the PERN network. There was an ongoing study of pediatric pneumonia that allowed us to kind of morph that study and rapidly launch research into COVID-19 across our networks. So what we started with, we called it the PERN COVID study. It was a prospective cohort study of children with suspected SARS-CoV-2 infection who were evaluated in emergency departments around the globe. And so as you can see here, a bit of a description, there is kind of a bit more of a preponderance of sites in Canada, the US, but we do have a strong representation from parts of Europe, with several sites in South America, as well as Central America and Australia and New Zealand. What we did in this study is we actually identified children when they came to the emergency department, and we were a bit at the mercy of the testing strategies being employed, which varied across the globe and even within sites and over time. But we did identify them when they came and sought care. They were tested for SARS-CoV-2. When we obtained the results, we would then contact them, both SARS-CoV-2 positive as well as negative children. And the latter was an important part because it allowed us to identify a SARS-CoV-2 negative control cohort to a large degree. We evaluated them for evidence of signs or symptoms of potential acute infection, so we wanted to know why they were tested. Epidemiological risk factors, we collected extensive demographic medical history about the current illness and their signs and symptoms. We looked at all the investigations that were done as well as their outcome from their emergency department visit. 14 days later, we recontacted all of the caregivers again, and we wanted to know how their child did, if they had any subsequent return visits for medical care or additional SARS-CoV-2 testing, because as we know, children could be negative at the start, very early on in the illness, and they may have had a repeat test done several days later. So we wanted to appropriately classify all children. We did a medical record review at 30 days, and actually we did a follow-up phone call. We had planned this from the get-go of this study to look at chronic symptoms. We didn't really know our foreshadowing of the long COVID pandemic that would be coming. And so we actually contacted all caregivers at 90 days following their initial emergency department visit. In this first study that we published, we looked actually and tried to identify predictors of severe outcomes in children who were tested for SARS-CoV-2 in the emergency departments. As you can see, we ended up enrolling over 3,000 children who were SARS-CoV-2 positive. Of these children, 79% were discharged from the emergency department. And of those who were discharged at that index visit, there were no deaths, and 12 of these 2,500 children who we had follow-up for, or 0.5%, met our study definition of a severe outcome. And we really focused our severe outcomes on critical interventions. Admission to the ICU, mechanical ventilation was our main focus. Amongst those who were hospitalized, which was 21% of our cohort, 91 or 13% were directly admitted to the intensive care unit. And in this group of children, there were 4 deaths, accounting for 0.6% of all children, but severe outcomes were a lot more common, as you can see, accounting for 14% of all children. And what you can see on the right here is we look for predictors of severe outcomes. And interestingly, I highlight Canada having an odds ratio of 0.11 for severe outcomes. And many people have asked me why, relative to these other countries with the US as the reference, was Canada lower. And I think it actually relates a lot to our extensive testing that was done early on in the COVID pandemic. We were actually testing all children, particularly those, anyone who came to the emergency with any potential symptoms of COVID. Whereas the referent, which was the United States, a lot of our sites, especially the first 6 months of the pandemic, they were testing children who were hospitalized, and some sites had it limited and restricted to those being admitted to the ICU. We looked at ages, and we found that older children, as opposed to younger children, which is what we typically see with a lot of viral respiratory diseases, were actually at higher risk for severe outcomes. We found that if they had a chronic condition, or if they had a prior episode of pneumonia, they were more likely to have a severe outcome. And lastly, the children who had more symptoms at the time of their initial ED visit. So if they presented with 4 to 7 unique symptoms, they were more likely to have an adverse outcome. We did see that trend continue if they had greater than or equal to 8, but as you can see, very few children fell into that category. Our next study that we looked at was treatments administered to children. So as there was emerging evidence, and actually in numerous studies that we've all seen published in high impact journals, massive sample sizes with interventions, and using very critical outcomes, particularly obviously mortality often, hospitalization. In children, there has been a paucity or almost a complete absence of clinical trials. So when we looked at our cohort, we were interested in determining if children were actually being administered treatments for COVID infection. And the most common one that obviously had the greatest body of evidence early on was corticosteroids. So we looked and compared kids who were COVID positive to those who were COVID negative. And we actually found that corticosteroid use was less common among SARS-CoV-2 positive children compared to children who are SARS-CoV-2 negative. When we then looked at what was associated with its administration, we found that increasing age, history of asthma, wheezing in the emergency department, study month, hospitalization, and ICU admission were associated with administration. We then factored into our model the SARS-CoV-2 test results, and we found that overall, and even amongst the subgroup of children who were hospitalized, SARS-CoV-2 test positivity was not associated with corticosteroid administration. And when we looked at all the other treatments commonly used or administered to adults who are hospitalized and critically ill, we found there were very, very few treatments administered to SARS-CoV-2 positive children. So one of the other features that we looked at is the post-COVID condition in children. So we looked at our cohort overall. We actually had to stop this study on January because we needed a lag time for our 90-day follow-up. So we did have over 2,300 SARS-CoV-2 positive children, of whom 1,800 were hospitalized and 1,800 were not hospitalized, 564 who were hospitalized. And when we looked at their rates of reporting the post-COVID condition, defined as any new recurrent or worsening symptom 90 days following their initial test result, we found that this occurred in 4.6% of those who were not hospitalized, as compared to 9.8% of SARS-CoV-2 positive children who were hospitalized. We then looked at factors that were associated with reporting the post-COVID condition, and we found that older children, relative to those less than 1 year of age, so most greatest in the 14 to 18-year-old age range. Once again, the number of symptoms at presentation was associated with post-COVID condition at 90 days, and if they were hospitalized for the acute illness. When we compared the SARS-CoV-2 positive children to our children who were followed identically but were SARS-CoV-2 test negative, if you were hospitalized, and the numbers change a little bit from that earlier slide because not all, we actually did a matched design here where we wanted to match children by site and seasonality. The hospitalized SARS-CoV-2 positive children were more than twice as likely to report the post-COVID condition, so 10% versus 5%. Whereas amongst those who were not hospitalized, while it was more common, the difference did not achieve statistical significance at 4.2 versus 2.7%. We then did a regression model where we factored in the SARS-CoV-2 test result status, and we actually found that it indeed was overall associated with the post-COVID condition with an odds ratio of 1.6. One of the other things, we partnered with our lab here in Calgary, and actually for this study, we utilized only Calgary specific data from the Alberta Children's Hospital. And we actually compared our standard of care, which was a nasopharyngeal qPCR result run by APL, with a nasopharyngeal residual specimen ddPCR result. So this approach actually generates droplets where they then each undergoes PCR amplification and the fluorescence, which allows us to truly quantify the viral load as opposed to an amplification and extrapolation curve, as you see on the bottom. And it is actually considered a more sensitive approach. When we did this, we found that 95% and even 95% of the positive RT-PCR specimens and 40% of the negative RT-PCR specimens included in this study were actually positive on our ddPCR, yielding an overall sensitivity of 84 and 97% respectively for these two approaches. But we found that overall, this rate of obviously concerning positivity amongst our RT-PCR negative specimens was quite concerning. We attempted to correlate this with clinical symptoms, and our sample size was quite small, but it does show that there is a concerning discrepancy and discordance between these two different approaches, especially with the ddPCR being more sensitive. However, the challenge is interpreting whether these children who are ddPCR positive represents true a live virus that is capable of being transmitted and causing symptoms. And so that really has yet to be determined. The last study I'm going to discuss is an ongoing study that we're doing currently in our Pediatric Emergency Research Canada, or PERC network. This is going on in all 15 emergency departments across Canada that are members of our network. And this was in response to Health Canada, who solicited evaluation of a device. And the device is the Abbott ID Now, which is a point of care PCR device that provides a result on a specimen within 10 minutes. And if it's positive, it actually usually provides it within 2 to 3 minutes of starting the process. So what we did is we're currently enrolling children who are undergoing standard of care nasopharyngeal swab testing that is being sent for qPCR. We then are recruiting families that are willing to have them or their child do a self or caregiver performed buccal swab PCR. So they're actually swabbing their inner cheeks on both sides. We then run it in the emergency departments of our participating hospital. We obtain the result within 5 to 10 minutes, and we do inform the clinical staff and the caregivers of the results of the buccal swab PCR results. So to date, we've enrolled over 1,300 children with results in our database. We have approximately a 20% positivity rate. Our sensitivity actually is lower than what we had hoped for and anticipated at 56%. Interestingly, we have dramatic variation across sites, with some being as high as nearly 70%, with others being as low as 10 to 15%. So we're looking at trying to figure out why we have some of this overall discordance. Not surprisingly, the specificity is 99%. So if you are positive, it is almost certainly a true positive. And that kind of, if you look on the upper right, the positive predictive value is 95% with a negative predictive value of 91% and overall test accuracy of 91%. One of the really important, interesting considerations is here in the bottom left-hand corner. We actually have asked the child and the caregiver to rate their pain and discomfort associated with performing the swabs. And when we on the left here, we asked the standard of care COVID-19 swab was associated with minimal pain and discomfort for my child. Very few, as you can see, about 5% strongly agree, with the vast majority being on the bottom 2 bars of disagree or strongly disagree. When we asked them about the cheek swab, what you see is almost everyone strongly agrees or agrees. Now, this has implications for those who are frontline healthcare providers, is we have testing fatigue in our population at the moment. And what we have found is even in children where there is a very high risk of having and likelihood of having COVID who present to the emergency department, there is limited to no desire by a huge proportion of caregivers to have their child undergo a nasopharyngeal PCR test at this point in time. And that is a major challenge and concern going forward, both for this pandemic, as well as for future pandemics when we start asking our population to come to testing centers and undergo nasopharyngeal swab testing. So we do really need to start looking at alternative approaches. And on the bottom right here, just a little graphic of where even a test like this, where the sensitivity is low but specificity is very high, is where it could be helpful if you have a non-invasive test. But if you look here on the bottom where the test is really done to rule in the condition and you have uncertain or unlikely or very unlikely, so a low pre-test probability, the positive test dramatically raises your post-test probability. On the other hand, if you have a very high pre-test probability, such as we had in January and February in most of Canada with the surge of the Omicron wave, it doesn't make much sense to test because even a negative test does not dramatically lower your post-test probability because the sensitivity is not quite as high as one would desire. So in summary, I think our research program has demonstrated a few important points for practice and policy. So if children are sick enough to be hospitalized, severe outcomes are not infrequent, and the characteristics that we identified can guide the care of high-risk children. And actually that then leads into the next piece, where some of these high-risk children can form the cohorts for treatment evaluation studies, because really there are a few treatments currently being administered to children with COVID-19, and research is desperately needed to inform care, because we still do see children who are quite sick and being treated with really with care which is not based on evidence to guide that standard. Post-COVID conditions are uncommon in children, but they do occur. They are more frequent than older children, especially those who are hospitalized with more symptoms. Nasopharyngeal PCR has suboptimal sensitivity in general, but in children in particular, as we showed in this cohort. And given the pain that it is causing to children and the fatigue that we are seeing in our society, we do need to develop alternative strategies for future pandemics. And the last piece is that buccal swabs are a much more acceptable testing option for children and caregivers. And this may be an option when the prevalence is low, even with a device like this. But ideally, if we actually kind of maybe combine some of the technology that's evolving, such as ddPCR, make it more accessible and amenable, could that be used on a device or a specimen obtained by buccal swabs? That really remains to be determined, but it's something that I think we need to be exploring as we continue to move forward into the future. Obviously, a huge thank you to all the funders who made this work possible, and thank you very much.
Thank you, Dr. Friedman. Lastly, we have Drs. Tuff and Mcdonald, co-principal investigators of All Our Families study. Dr. Suzanne Tuff is professor with the Departments of Pediatrics and Community Health Sciences in the Cummings School of Medicine. Dr. Tuff is and has been a member of national and international advisory boards, including the World Health Organization Preterm Birth International Consortium, the Canadian Maternal Infant Child Youth Research Network, and CIHR Institutes. Dr. Sheila Mcdonald is a scientist in the maternal health, child health in the Department of Public Health Evidence and Innovation in Alberta Health Services. Her research focuses on early developmental threats to later life outcomes and protective factors that foster resilience for families. Welcome.
Thanks, Danielle. So I'm going to chat today on behalf of Sheila and myself on the experiences of families during COVID-19, but I want to acknowledge that the work has been funded by a number of Tri-Council grants and some subspecialty grants on screen time, and as well to recognize our co-investigators, Sherry Madigan, Nicole Racine, Brianne MacArthur, and Erin Hetherington, as well as our longstanding collaboration with Apron, another cohort. Next slide, please. So the All Our Families study is a longitudinal cohort that originated in 2008 and recruited up to 3,000 families, mother-infant pairs, into the study. We've been following these families over time and had completed our 8-year follow-up when COVID arose. The participants in the All Our Families study really represent the population. They represent the middle part of the bell curve. We have the same proportion of women in All Our Families who were 35 years old as you would expect in any pregnancy study. We have the same proportion who have completed post-secondary education and who were foreign born. Our median income is about $3,000 per year higher than the median family income in Calgary at the start of the study. But you might remember in 2008, Calgary was known for having slightly higher incomes. And just in terms of the characteristics of these families, they're typically educated, married, and employed, and 63% of them intended to vaccinate their children when a COVID vaccine became available. Next slide, please. So we asked families a number of questions over 3 surveys during COVID to understand the impact on this population. And they let us know that 58% of them had some form of financial impact described as either job loss or reduced hours in one or both of the parents. The financial impact, which might be of interest, affected all families regardless of their socioeconomic status pre-pandemic. And 23% of families experienced difficulty meeting financial obligations. And this is important in terms of a public health crisis, because when middle income families start feeling these kind of extreme circumstances, there are trickle-down effects across the community. And this decreased activity among all families is some of what we're seeing during COVID. So what I'm going to share with you today too will not come as a surprise. Mostly what this information does is help quantify the impact of COVID on the population. And the benefit of the longitudinal cohort is that we have information as to how these families were functioning prior to the pandemic. So we can see the real change in lifestyle and in circumstances. Next slide, please. So we noticed that rates of depression increased from 15% to 33%. So almost a third of all families were living with experiences of depression in the home. Maternal anxiety increased from 11% to 34%, a 3-fold increase over time. And just a reminder that these children are 9 to 11 years of age during COVID, so they're still in late elementary school. Women with income disruptions and difficulty balancing work and home, as well as schooling, which many families were required to do, and those who had difficulty obtaining childcare were most likely to be affected during COVID. Next slide, please. We were able for the first time to ask youth how they felt during COVID. And so these findings here come directly from the children in the cohort. And we noticed that over time, depression rates increased from 11% to 20% among these children, again, age 9 to 11. Anxiety rates increased from 16% to 19%. And these rates were higher among those children who had less connectedness to their caregivers, had less sleep, and experienced more screen time. I think it's important to know that the majority of these children were meeting physical activity guidelines prior to the pandemic, and the majority were also meeting sleep guidelines. So sleep guidelines for children at this age are 9 or more hours each night, and physical activity guidelines are 60 minutes per day, at least 5 days a week. Next slide, please. So when we looked at screen time, we aren't quite prepared to say that increases in screen time were problematic yet, given the severe circumstances of the pandemic, but it is true that screen time did increase among many children. What we noticed, though, and this work was led by Sherry Madigan and Brian MacArthur, was that those families that used screens to engage or connect with family saw some benefits. So many of us might remember using Zoom to connect with grandparents or family members. Families that were able to set limits were able to see a reduction in overall screen use. And I know that sounds maybe a little bit rhetorical, but it does speak to the value of routines and guidance, especially during times of uncertainty. And we did see that physical activity and recreation use did those families who participated in more physical activity and recreation, including playing games, were more likely and better able to reduce their overall screen use. So compared to pre-pandemic, about half of families struggled with physical activity and screen time guidelines at the end of the pandemic. So what does this mean, and what can families do? Next slide, please. One of the challenges with the pandemic is the lack of access to daily routines. So the 3 R's of support that would be beneficial for families are to really invest in resources, relationships, and routines. The benefit of resources is that it's able to reduce the physiologic stress that, in this case in particular, mothers felt while they were trying to balance everything that was asked of them during this time. And it is true, as we heard in our very first talk today, that about 75% of mothers assume responsibilities for most of the additional tasks that were revealed during COVID. Anyway, resources enables families to better function, enables some form of job stability, and facilitates skill development. Investing in relationships and social connections can increase our oxytocin and can normalize the challenging experiences that we had during COVID, increases people's sense of belonging, which can improve mood. And routines such as those associated with sleep, meals, recreation, and school can reduce decision-making fatigue. And I think that this is one of the underemphasized opportunities that routines provide, particularly during complex time. Reducing decision-making fatigue frees resources for complex decisions, and it actually helps children thrive. Next slide, please. So what communities can do to support families and children is invest in social snacking. And this work is being shared throughout Calgary through Connections First, and the website's at the bottom. This is work that will be shared through the City of Calgary and other municipalities, including the public library, on how to build naturally supportive communities using brief, informal, positive interactions. And why this matters so much in these challenging times is it increases our sense of belonging, again, helps us feel more normal, And when we feel like we belong to something, we're more likely to participate in our neighborhood, which increases community cohesiveness. And then our communities become a buffer for families that are feeling more challenges inside their own nuclear family. So look forward to social snacking and encourage yourself and your family members to say hello to somebody on the street or at the bus stop or in the coffee shop. Next slide, please. What decision makers can do, and we heard a little bit about the policy implications of this work earlier on in the session, that is really evidence informed from this work and many others, is to increase access to psychological services, including telehealth, and we've already heard a little bit about that. I think that we can support decision makers in prioritizing mechanisms for children and youth to stay engaged. Early on in the pandemic, you'll remember there were school closures. There was some debate in the policy world about the utility of school closures and to whose benefit they were. Our mental health data and that of others would suggest that children and youth's ability to stay engaged can be highly protective for their own development, both social and academic. And decision makers can also feel confident that investing in resources and supports to address family time crunch would be of tremendous value. You might recall that I said that women that had the most challenges during the pandemic with their own mental health were those that were experiencing severe time crunch in terms of balancing and juggling a number of competing obligations. These resources and supports come through activities like workplace protection and, of course, the newly announced federal guidance around childcare. I think that I'll go to the next slide. And just acknowledge that the collaborations around the All Our Families cohort are broad-based, and we really appreciate the support of funders and also the ongoing collaboration, as I mentioned, with APRIN, another longitudinal pregnancy cohort. And I'll pause there.
Great talks. We'll now start the question and answer portion of the section. So if I could ask the panelists to turn on their cameras. We'll start maybe with a general question for everyone. So what do your findings tell us about what we did well during the COVID-19 pandemic and what should have been done differently? I don't know who would like to start. Maybe if we start with Dr. Parkins.
What we learned was the power of transdisciplinary research and the ability of people with fractions of an expertise required to advance into a new area working collaboratively can very quickly bring and onboard a program. We've also learned that there are lots of administrative barriers that prevent rational and actionable programs from being fully rolled out, and that investments in technology are slow. Those were the biggest learnings that we had from the wastewater perspective.
Maybe if we move on to Dr. Tuff.
I'd say what families told us that they did well, despite the challenges they experienced with mental health and juggling responsibilities, was many of our children said they felt closer to their families. And so this ability to spend time together in games and shared activities, I think, was a positive. We also had a number of children, the majority of children said that they picked up some of the slack and did more chores than they used to do early in the pandemic. So I think some of the lessons learned were really relatable at the family level. I guess the other more broad-based thing that we did well was we felt that connecting with policy and decision makers to find out what questions they needed answered to make decisions was actually quite effective during the pandemic. So I would say we have more opportunity to do that in the future. I don't know if Sheila has another insight in that from the All Our Families cohort.
No, I'll just echo that, Suzanne. I mean, we do present a picture that families are struggling. which is true, experiencing stress, but there were some silver linings with adapting and adopting new routines and closer connections. So I think the virtual solutions really did help to bridge that gap. And I can't highlight enough, and Suzanne, you did that too, that social connections really are a buffering factor and protective factor in really investing in those relationships and adapting a new form on how to make those connections.
Dr. Friedman?
Yeah, I think it was quite interesting how quickly the global communities could come together to collaborate for research. Really within months, launching a global prospective cohort study, getting everyone on board there, and even though it was CIHR funded, the funding was not huge. So it really was a lot of labor of love and investment in the principle of collaboration, which I think was really impressive, but also taught us how much we need to have that scaffolding and infrastructure there ready to go. So preparedness is really super important. And the other piece, I think there was one of the linings, and in Canada, I think some of the data shows how well, when on this global scale, in this type of study, how well we did in the early days, in particular the pandemic, with our testing strategies. I think we were really at the forefront of COVID lab-based diagnostics and rollout in terms of surveillance. And obviously it's continued with some of the wastewater work that Dr. Parkins is doing and others, but really I think that was something that really made us different than many of the other countries included in that global project.
Great. Another question for everyone would be, what challenges have you faced with translation of your findings to both the scientific community and interested public? If you found any challenges.
Well, I can start that, Danielle, because we've had both successes and challenges. So the most interesting thing was that the work from the Connections First project, which ran in parallel to some of our investigation, which involved engaging the City of Calgary and municipalities in community building, I think was more successful because of COVID, because communities were really wondering what they could do. So I think that the fact that people were at home in their houses and in their neighborhoods actually made them more aware of the benefits of having some sort of community engagement. And so I would say that was interesting. One of the challenges, though, in translating something that sounds so much like common sense into policy is that people don't actually know what that action would be. And so what is the policy decision? Is it to deploy more resources at the community or family level? Or is it to teach people how to say hello to one another on the street? So even as this work unfolds, I mentioned with the Big Brothers, Big Sisters, City of Calgary, libraries and municipalities, there's a bit of, okay, it makes sense. And how do we do that? Which is interesting.
I have a couple thoughts as well. So I think, government agencies are very interested in the data. They wanted it very quickly, both in Alberta and at the national level, as well as at the WHO level. They were very keen to hear and see it and integrate it. I think translating and sharing the knowledge with the public happened in interesting manners. Loads of media interviews with, trying to share the knowledge with the public. Often, as we all know with media interviews, very hard to control what goes into the snippet that they take out of it. Most of the time, very good, but there often is a sensational spin that they always wanted to put on everything. And one of the other pieces that was interesting is, the academic world is quite challenging with COVID research, in the sense of it moves at a pace that none of us have ever seen before. And nobody cares about Delta anymore. No one even cares about BA1 anymore. So any research done up until March essentially is almost irrelevant in the now BA5. But it moves so fast. And I think the academic community needs to reflect on itself about the rigor of what is published a little bit, because so much of it is incomplete and published quickly. And then even, it was interesting for me, some of the articles and manuscripts I published, where I didn't do interviews, the headlines of the press could be totally opposite. One could be low risk of severe outcomes in kids, and the other could be high risk of severe outcomes in kids. And a lot of it relates to they don't quite understand the details of the research and how it was done. You know, obviously there's a lot more than what I presented today, for example, and they often just take like one line, one piece, and they translate that. So it was very interesting and challenging for many people to see how that all plays out when it's well beyond most of our control.
And Dr. Parkins, last.
Yeah, one of the biggest challenges to translating this has been the fact that this is research in action, and again speaks to the speed with which we need to move. We've gone from, in particular, the wastewater monitoring being a scientific curiosity that was explored through early CIHR programs, to then finding a situation where it's not really research anymore, it's a tool, but it's not a tool brought on under any particular umbrella. So finding the right groups to fund what everybody believes to be an important program has been a real challenge. And again, the ability to grow this program should be, in my opinion, a bit of a no-brainer. This is really powerful technology. And right now, where the costs of sample collection represent about 40 or 50% of our budgets, we should have no problems getting money to expand the analytes that we're monitoring to a bazillion other different things. But that just doesn't exist right now. Again, people are very COVID focused.
Great. Well, thank you very much to all the speakers and everyone who has attended. My understanding is now we'll be taking a 5-minute break.